half of Dr. Palmer's presentation on Mercury 101. And then I'm going to start up right at 11, and then we'll have lunch at 12, okay? So there'll be no more breaks until lunch. So without further ado, Joe, carry on.
All right, so that first study we did, we were not able to get published. So one reason was the people who were doing the peer review weren't dentists, and they had no idea what we were talking about. The dangers of mercury, or even that one of them said, patients still have mercury in their teeth. Dentists are still using mercury, you know, the same thing you always get. So, and they finally said, you need to have more data points. We had 20 sets. We thought that would be enough. They said we didn't need more. So, okay. So Dr. Warwick and Dr. Young came up with the idea, let's dumb this thing down for them and get more data sets. So what we did, we took, this was from actual patients that were using mercury removal, of course, with all the protection. And then as soon as they took all the mercury out, we would wipe the head of the handpiece, send that in for testing, and quantitate the particulate and the vapor emitted off that sample. And we found out that it was huge. We showed that the safety thresholds for mercury exposure can be exceeded during dental procedures involving drilling on amalgam fillings if special precautions are not in place. Further indicates that standard methods appear to be inadequate when assessing mercury exposure during drilling on dental amalgam because these methods do not account for an overlooked source, mercury vapor emitted from particles of the filling that are generated by drilling. So, I mean, the kind of standard way to test that was just stick the vapor hose in there and try to see how much vapor is coming off as we were drilling it. So we were missing half of the contamination that was happening. From our unpublished data, we knew that particulate can go all the way around the room, or we assume it did. We knew it came close quarters to where we were testing, and that even our large suctions couldn't capture it all. And we also learned that as we didn't have those large suction devices or the other engineering controls on, it even got higher. Because every time we took one control off, we saw the rates of particulate, the amounts of vapor go up. So from these two studies, we know that you are going to be exposed to mercury vapor and particulate as you remove dental amalgam fillings. So what do you need to do? You got to protect yourself and you got to protect the patient. And we'll go to protocols that we've developed to let you do that. So this is a photo that shows all the techniques that we use. We use gowns, and you don't care what gown you use, but you should try to cover yourself from the top of your head to your feet. I wear a Tyvek suit that has booties in it. It has a hood. This is a shield. There's a, this thing have a pointer, guys? Oh, there we go. So it's got a plastic shield on. Got a, this I think it's a jack. So he's actually hooked up to an oxygen source. So he's breathing oxygen rather than room air. There'll be pictures of respirator masks that we have also available. The patient's covered down to their toes, rubber dam, suction. You're missing a few things in this picture. High volume suction, we'll just show you later. But I just tell the patients, and by now, patients come to me, they already know we're going to do this. They've seen it on the website, and that's why they're coming. One of the reasons they're coming. And so I just tell them, I'm going to look like I'm going into outer space. You're going to be totally covered up. You're not going to be breathing room air. You're going to be breathing oxygen, which is what they're looking for.
So the results of the study basically confirm that we are underestimating a source of mercury, and it can have massive implications on how dentistry is practiced. The amount of particulate that comes off of these dental fillings when they're drilled is monstrous. And unfortunately, in a regular practice, this particulate is not treated as anything that's of significance. So it changes how we think about doing things. And in this case, we'd want to mitigate any possible exposure to both the dental worker and also the patient. So it means completely respecting that exposure, removing it from the office as quickly as possible, knowing where this material can land, and maybe even the design of the dental operatory itself, and how we handle this material. We also have to understand and respect the fact that mercury vapor is absorbed via the skin. So that means that skin has to be protected from the source. So any possible skin exposed to this particulate has to be covered by some form of barrier that is resistant to mercury vapor getting through it. The implication of what we found in this study goes to the practices making changes in how we protect especially our staff. This is an occupational matter. If you understand that when you do drill out mercury fillings, that this particulate is being spread out all over the place. Some of the important areas that we have to consider especially are in the dental workers' wrists, their hands, their forearms for sure, and understand that this exposure is an everyday occurrence that may happen 3 or 4 times a day. So we have a big problem, and we have to start recognizing that this particulate, this waste, is a big deal. And the first step, in my opinion, to trying to mitigate this exposure is to stop putting it in the first place. We have to start looking at the alternative materials. They're safe, they're effective, they have longevity, and if you consider the environmental impact and the cost of use through its life, amalgam fillings are the worst and most expensive material that we can think of using.
We've had some other occupational research been done. Dr. Tom Duplinsky looked at the health status of dentists exposed to mercury from silver amalgam tooth restorations and published it in the International Journal of Statistics and Medical Research. Now, Dr. Duplinsky is at Yale. He said it would seem prudent to advise that dentists consider using restorations that do not contain mercury. He showed that dentists require more medication the older they get, and a lot of it's for neurological disorders, for Parkinson's, for a lot of the diseases that affect the neurosystem, for cardiovascular disease, just kind of across the board. If you take dentists and look at them as a group, we take more medication for chronic disease than the normal population. Then Warwick and O'Connor and Lamy did mercury vapor exposure during dental student training in amalgam removal. Now this Warwick happened to be Dave's daughter. And from that study, they showed that a lot of times in the didactic labs, I mean, the students are getting a huge exposure to mercury because most of the time they're just cutting, old amalgams out dry and replacing them just to get it out of the way. And it is paramount that dental schools consider how dental students are trained in the subject of mercury hygiene when removing dental amalgam, as well as other procedures where mercury exposure may occur. They must also train dental students in the effective use of personal protective equipment in order to prevent occupational exposure to mercury while in dental school and in clinical practice. Well, dental schools say, well, it's not an OSHA violation because they're students, they're not employees. So they don't do much to do that. Other research have found higher levels of mercury in dental workers, that pregnancy, fertility, and gender-specific risks to female dental workers occur, and dentists have increased skin hyperpigmentation, respiratory disorders, irregular pulse, hand tremors, spasms of the upper extremities, neuropsych symptoms, tachycardia, painful chewing, thyroid enlargement, fears, and difficulty in writing. Maybe that's why we can't write. In Mutter in 2011, neurological issues such as memory loss, concentration issues, fatigue, and sleep disturbances. Ritchie, renal and memory issues, and Echeverry, depression and impaired visuomotor speed. So that's just some of the published studies. I mean, there's many, many more on our website. All right, let's look at how to protect ourselves from this stuff. And we call it the SMART technique: safe, mercury amalgam removal techniques. So the basic facts and common reasons for taking the amalgam out are device failure, the things break. People want them out for cosmetics. Patients will walk in and say, I'm tired of this stuff, I'm ready to get it out of my mouth, because they're aware that they have mercury in them. I can't tell you I've ever seen anybody come in with allergies to amalgam, and that's the reason. But there are people who are allergic to mercury. The dangers of removal without safety measures are exposing yourself. Heck with the safety limits, you can pick the one you want, but you're gonna go over it. You're gonna expose the patient more than they have to be exposed. And then we're in a chronic situation. We do it every day probably, so you have more exposure than a specific patient. But that doesn't mean you don't do harm to the patient if you take out a bunch of mercury on them, because they have a huge exposure on that time. They could have acute poisoning, some of them. Secondary exposures in less obvious office areas are to staff, patients, and visitors in other parts of the office. Like I told you when we did our study, that mercury got transported to another part of the office, and we were over there and thought we were just safe, took off all our stuff, picked up a mercury vapor detector on that side, and it was huge on that side. So I said, let's get out of here, and we opened up the windows in that office, left them open all night, ran our suction units, air purifiers all night, came back in there the other day and did some work back there on put Randall's fillings out. Randall's back there. So it can get transported throughout the whole office. So just because you're in the back, that doesn't mean you're not exposing your front desk person. Environmental mercury exposure caused by the waste. We should be responsible and make sure we have a good separator. Storage and disposal of workplace protective clothing and instruments. This is a hard one because you create a lot of waste. So the protective clothing itself, which you'll see in a minute, I actually dispose of it out back immediately in the trash cans. The more contaminated stuff, or what I can see is contaminated, like our gloves, the rubber dam that's covered in it, that goes and gets recycled. So we store it and then recycle it when the bin gets full. Mercury vapor exposure from sterilization of instruments. So you put your instruments in there and they're covered in mercury particulate. Once you heat them up, or even in the little triturator cleaner thing, then it's going to release mercury vapor into that room. Mercury on clothing, carpeting, drapes, and other areas. You need to get all the soft material out of your operatories. Even if you moved into an office and bought a practice or something, and the dentist in there has been doing mercury for years, you need to replace all the soft stuff, even just carpet in the front. When we were doing our study, we were checking the environment to see how much mercury contamination was. The drapes were actually pretty good. They weren't too bad. And I had some soft drapes. And I had this big room where I used to teach CEREC to like 10 officers at a time. And then when I got terminated from doing that, I went ahead and put a chair on one side of the room. So I had two chairs in this big room, big space in the middle. I still had a big island. And but in that space, I had an oriental rug, about a $3,000 oriental rug that I just put there and left there. And my daughter wanted it. She knew we were moving. She wanted that rug. And I said, well, let me check it. And so when we were checking everything, we were picking up a lot of mercury vapor out of that rug. So before we ever started, I said, okay, guys, let's grab this rug. And we took it and threw it in the dumpster. My daughter was sick. I said, you can't clean that stuff. You can't decontaminate it. I didn't want my grandchildren crawling around on that rug. So we got rid of that rug. And so it does get into your clothing during the day. It'll get into your carpet, and it'll get on your drapes. You need to get rid of all that soft stuff in the operatories. Because if it gets on your clothes and gets on your shoes, you're going to carry it home. And if you don't take those shoes off, you're going to get in your carpet in your house if you have carpet. Or you're going to get it in surfaces in your home. And you're going to start to contaminate your family. So you need to leave it at the office. So a little bit of the history of the SMART technique. We knew, IAOMT researchers knew the dangers of fillings back in 1984. They constantly update removal recommendations with science, and we did all this science before we changed and made our latest recommendations. And I stood up here and fought for that, and Griffin helped fight for that. Some people fought us on it, but we got it pushed through. So we renamed it SMART in 2016, and you can have a SMART certification. a training program for dentists to learn SMART in 2016. Now, we have different levels of accreditations or different levels in the academy that you can reach to show your knowledge, to show you're dedicated, show your enthusiasm for biological dentistry. And the first step was accreditation. And this course was part of accreditation requirement. I urge you to seek accreditation, but you can get SMART accredited quicker. We make it real easy. You just got to buy the stuff, do a little bit online, show that you know what you're doing, and we will give you SMART accreditation on our website. And patients are starting to look for SMART accreditation. They also look for those other levels of accreditation, fellowship, and mastership. So, and there's one more, right? So it includes the public awareness components of the SMART choice. We have websites that the public goes to. So I'm telling you, your patients know this technique. If they've researched it and you leave a step out, they won't come back and they won't refer to you. So development SMART is built upon years of clinical research and experience. It took 4 years of research to even make the change. There are additional things we require from what we used to require. So we had IAOMT researchers completed PubMed literature search of all 94 published journal articles on dental mercury amalgam removal to develop initial SMART protocol recommendations. We will update it again if we find some science that says we should, or we find a better material. Maybe we find a perfectly impervious garment to mercury paper. We'll get rid of that. We'll add that as a recommendation, but we haven't found that. And then we have the scientific recommendations are on our website. You can go there for the references. So Dr. Cole, see, he looks a hell of a lot better than I do, is our spokesperson for SMART.
I'm Dr. Griffin Cole of the International Academy of Oral Medicine and Toxicology. Patients and dentists should make sure that each step of the safe mercury amalgam removal technique, or SMART, will be applied during a dental appointment for filling removal. The first step is for patients to consult with their dentist before the mercury filling removal begins, so that both the patient and dentist agree that all safety measures will be in place. This helps to ensure that the patient and dentist know exactly what to expect. It's also helpful to watch the following example of the safe mercury amalgam removal technique, or SMART, being applied. Each room where mercury fillings are removed should have adequate filtration in place, which requires a high-volume air filtration system such as IQ Air Dental Mercury FlexVac or similar device, capable of removing mercury vapor and amalgam particles generated during the removal of one or more mercury fillings. If possible, windows should be open to reduce the mercury concentration in the air. The patient should be given a slurry of charcoal, chlorella, or similar absorbent to rinse and swallow before the procedure unless the patient declines or there are other contraindications making this clinically inappropriate. Protective gowns and covers for the dentist, dental personnel, and the patient should be in place. All present in the room should be protected because substantial quantities of particles generated during the procedure will elude collection by suction devices. It has been demonstrated that these particles can be spread from the patient's mouth to the patient's knee and to the chest, shoulder, and neck of the dentist and dental assistant. Either a properly sealed respiratory grade mask rated to capture mercury or a positive pressure, properly sealed mask providing air or oxygen should be worn by the dentist and all dental personnel in the room. Non-latex nitrile gloves should be utilized by the dentist and all dental personnel in the room. Face shields and hair head coverings are to be utilized by the dentist and all dental personnel in the room. In order to protect the patient's skin and clothing, a full-body impermeable barrier should be utilized. External air or oxygen delivered via a nasal mask for the patient also should be utilized to assure the patient does not inhale any mercury vapor or amalgam particulate during the procedure. A nasal cannula is an acceptable alternative for this purpose as long as the patient's nose is completely covered with an impermeable barrier. A saliva ejector should be placed under the dental dam to reduce mercury exposure to the patient. A dental dam that is made with non-latex nitrile material should be placed and properly sealed in the patient's mouth, as well as a full head, face, and neck barrier that is under and around the dam. During amalgam filling removal, the dentist should utilize an IQ Air Dental Mercury Flex Vac or similar device in close proximity to the operating field, that is 2 to 4 inches from the patient's mouth, to mitigate mercury exposure. High-speed evacuation produces better capture when fitted with a cleanup device, which is preferred. Copious amounts of water to reduce heat and a conventional high-speed evacuation device to capture mercury discharges should be used to reduce ambient mercury levels. The amalgam should be sectioned into chunks and removed in as large of pieces as possible using a small diameter carbide drill. Once the removal process is complete, the patient's mouth should be thoroughly flushed with water and then rinsed out with a slurry of charcoal, chlorella, or similar absorbent. During the opening and maintenance of suction traps in operatories or on the main suction unit, dental staff should utilize the appropriate personal protection equipment described earlier. An amalgam separator should be properly installed, utilized, and maintained to collect mercury amalgam waste so that it is not released into the effluent from the dental office. Dentists must comply with federal, state, and local regulations addressing the proper handling, cleaning, and/or disposal of mercury-contaminated components, clothing, equipment, surfaces of the room, and flooring in the dental office. I hope that you'll make the smart choice about your dental care by asking for safety measures during your mercury filling removal. For more information about the Safe Mercury Amalgam Removal Technique, or SMART, including scientific research about why these safety measures are important, visit thesmartchoice.com from the International Academy of Oral Medicine and Toxicology.
All right, so we're just going to kind of go into the weeds a little bit on each of these steps, okay? So a slurry of charcoal, chlorella, or similar sorbent for patients to rinse and swallow before the procedure. That just gives them kind of a barrier in there. You can also use N-acetylcysteine mixed with some vitamin C, which is what I use. You can make that up every day fresh, have them rinse with that, and before the procedure and after the procedure. And after the procedure, don't let them swallow. Use full body, impermeable as we can get barriers, as well as full head, face, neck barrier under around the dam. So I use Tyvek material in a hood out of Tyvek. You can use painter's plastic. I mean, you could use a surgical gown on the patient, but they're a little expensive to be doing that. So some type of barrier. Tyvek's made to breathe, so it's not totally impermeable to vapor, but it's made to, that's what they make the biological suits, hazard suits out of. So it's made to block particulate, okay? Like COVID and mercury particulate. You need an external air or oxygen delivered via nasal mask for the patient, or a cannula completely covered with impermeable barrier. Now this can come off a nitrous unit. I just take my nitric oxide units and just put the oxygen on, unless they're wackos and need the nitrous too, okay? Non-latex dental dam, nitrile material placed and properly sealed in the patient's mouth, we found is more impermeable to vapor than just a regular rubber dam type. Saliva ejector placed under the dental dam. At source, oral aerosol vacuum in close proximity to the operating field, which is the IQ or the dent air vac. Cleanup device. Now, this thing, when you start using it, it's going to be a pain in the butt, okay? You're going to say, why am I messing with this? Does it really work? Well, in our studies where we took off every engineer control, we had a significant increase in particulate and vapor when we didn't use that. Some tricks on using this, it's a little long at times. If you're trying to work on a tooth that's clamped, take and trim it a little bit so it goes down and fits better. And you want to try to make a good seal as possible. And then sometimes you can't use it, guys. You're just not going to be effective. So then just take it off and use your regular evacuation. So lots of water to reduce the heat like you would anyway. Conventional high-speed evacuation device to capture mercury discharges, which is what you're going to be using now. Take it out in bigger pieces as possible to cut down on the particulate. After removal, the patient's mouth should begin washed out with water and rinsed out with some kind of irrigant that will capture the stuff that's going to get by the rubber dam. Even if you can't see it, I promise you something's getting by that rubber dam. So charcoal, chlorella, or N-acetylcysteine, and vitamin C. All right, you need to protect yourself too, and the patient also, with gowns and covers for the dentist and dental personnel. You need to use light nitrile gloves. Most people are probably not using latex. Too many of your patients request non-latex gloves because they are less impervious to the vapor. Face shields, hair head coverings for the dentist and dental personnel. So most of the time the assistants don't really love garbing up because it's going to give them a bad hair day. So when you take the stuff off, sorry, you need to do it, okay? You need to cover your hair. And then you have a properly sealed mask, respiratory grade mask, rated to capture mercury, so it'll have some type of particulate filter on it, or properly sealed masks providing air, not room air, or oxygen for the dentist and dental personnel. During the opening and maintenance of suction traps, you should also have a mask on and some protection on. So there's different kind of masks. I mean, this looks like an N95 mask, but it's got a mercury particulate thing on it. Then we have respirator masks that have these filters on them. We have these available, I guess, at the booth. You bring this stuff, Farrah? We have some of these at the booth to try on? Okay. So in our booth, we have some of these different masks. You can kind of try them on for size. The most important thing you can do to protect yourself or start protecting yourself when you get back is to get one of these type masks ordered. These you can wear like cheater glasses in or prescription glasses. There's a thing that you can get to go with them, but you can't wear your loops. So a lot of people like to go this kind of mask and a shield, and you should be able to wear your loops. And I think that's adequate. So again, in protect the environment, we're talking about a separator that's properly installed and maintained. High volume air filtration, the ADA's gone berserk now with COVID, right? What are they advising us to do? Have high volume particulate evacuation in the office because of COVID of all things. What happened to AIDS and, that's bloodborne and other stuff, common cold, but now they're going berserk. And they hadn't read these studies, although we've sent them to them, about the particulate for mercury. So we've been doing this stuff for years. So when COVID came along, it wasn't a big deal. We're doing it anyway. Let's just keep doing it. And then the other guys are freaking out. If possible, just get a lot of circulation in the room as much as you can. And whatever your state codes are on cleaning or disposal of mercury-contaminated components, clothing equipments, flooring in the dental office, those kind of things. I'm in South Carolina. We're a red state or something. We don't have hardly any regulations. But don't call them up and say, hey, can I throw these mercury-contaminated gowns in the trash can? Don't ask them. They aren't. Just do the right thing. Recycle what you can. And there's different mercury recyclers. And then that's the little stuff because you can't afford it. If I was doing all the gowns, I'd probably be doing 4 or 5 canisters a day. That'd be over $2,500 a month just to get rid of some gowns. And they're going to look at them and go, what the hell are these for? They probably won't get them and throw them away. So when you send the other stuff, they know there's mercury in there. So we encourage dentist-patient communication about the mercury amalgam removal procedure. The SMART checklist of patient, dentist, staff, and environment protection you saw in the preceding 6th slide is available for no charge at the website, smartchoice.com. You are going to need, if you're not doing any of this in the office already, you're going to need to teach your team members why this is important and the protocol. Okay? You can use this website to help you do that. And for those that resist you and try to fight you and tell you you're stupid and that you're not going to have anything to do with it, say fine, find somewhere else to work. And I mean tomorrow. Because you don't need that hassle of patients trying to keep you from improving your practice and your staff and your technique you're doing for patients. You're doing a better job for the people who are important in the office, and that's the guests that come to you to get treatment. So if you get an employee that's adamant, I'm not doing this, no way I can put that mask on, well, go work for an amalgam dentist. We'll get somebody else. There's good people out there. So most consumers today don't want mercury fillings anyway. I mean, the only ones that do are so tight, they're just looking at what their insurance pays. So when I first started doing this, I told my patients, I said, look, I'm going to protect myself when I take this mercury out of your mouth. Do you mind if I protect you? Oh, no, please do. And a few, one or two, said, well, my insurance pays for composites. And I go, what I do? Pay for composites. And I said, not sure, but probably not. They'll pay a little less, but they'll still pay something. I said, if you want an amalgam, there's a good dentist right down the street. He'd be glad to do it for you, but I'm not putting an amalgam in again in my life. And I may have lost 2 patients, I think. And I was in a redneck little mill town when I was doing that change. Recent studies have debunked the claim that composites are not as durable as amalgam. Composites are done well, they can last a long time. I tend to go, if they get too big, I'm going to go to porcelain. And you now have materials that don't have bisphenol A in them. Admira Fusion and Fusion Extra, released in January of 2016 by Boco, is being touted as the first purely ceramic-based restorative material that doesn't have bisphenol A. It's a different kind of chemistry. We're not sure what all the other stuff is and what it might have complications, but that's the composite I use. Glass ionomers, they contain comprimers, contain fluoride. I don't use those. If you're going to use them, you need to make sure, especially in a biological practice, that patients are aware of that. They probably won't want them. You can use biocompatibility testing again, like I said. Toxic or immune illness is a medical diagnosis not usually allowed under a dental license. You can pre-screen, but don't diagnose mercury toxicity, okay? Leave that to the doctors. So, if you're not a member, we got any people out there that are not members? Everybody's a member? Good, thank you. And how many of you are you SMART certified yet? You are? Great. So get your SMART certification first, and then look at the other accreditation processes. And once you're a member, you can go to the website for the library, and there's tons of information there. Okay? All right. I think that's it, and we should have about 10 minutes for questions. Okay?
So I want to know how much of the tooth structure will be lost when taking out an amalgam filling, and when do you decide that it's not worth the risk if it's a big amalgam filling and versus just getting the tooth pulled?
Depends on what my guest wants. But you do that like you do any other decision process in your brain. If it's a huge filling that's already deep and on the pulp and it's symptomatic tooth, then we got to discuss that with the patient beforehand, because any further trauma to the tooth is liable to kick it over and be, irreversible pulpitis, and most of these patients are not going to want root canals.
How much of the tooth structure do you lose with a normal, when you're taking out an amalgam?
Well, hopefully none, but none. I think, it usually pops out pretty good, but the restorative that you put back is where I look at how much tooth structure I have to remove, because that's how I'd make a decision on which restorative material am I going to use. If it's very small, I'm going to stick with composite, because you got to have a certain width and depth for ceramic restoration, okay? And for ceramic restoration, for me, it's not a crown most of the time. It's an inlay or an onlay. And I mean, I was a CEREC instructor during the early days for about 9 years, and I saw the progression of dentists buying the CEREC system. And the original ones that bought it, we could only do inlays and onlays. And then we got to a point where it was 3D and you could do crowns, and all these dentists were trying, all they wanted to do was crowns. And I said, you are mutilating this system. That's what this is fine for. Bonded ceramic restorations are designed to save as much tooth structure as you can, not cut it away and just do a crown. So I look at that more as which restorative material is going to maintain the most tooth structure.
And one more question, you may or may not be able to answer this, but what agencies are being paid off in order to keep amalgams legal?
I don't know where the money's flow is, but the ADA is protecting their butts because they've advocated for so long. They own all the patents and stuff, and they're scared of lawsuits. But when they get a lawsuit, they just get out of it and say, hey, we don't control that. We don't control dentistry. And then they turn around and, of course, they do have pressure on controlling dentistry. So I don't know that. I don't know the answer to that. Dr. Kennedy, you might ask Dr. Kennedy that when you catch him in the hall. Come on, I didn't do that good a job. Right up here.
You pass the microphone. Thank you.
So the smoking tooth effect was pretty cool. I was just curious with a hygienist, we saw like the eraser on the tooth and how it compared it to like a tooth cleaning almost.
Mm-hmm.
So does the hygienist get exposed to that vapor each time she's doing the teeth cleaning with the?
Every time the patient opens their mouth and breathes out.
Yeah.
Yeah, so I tell my hygienist don't use a Profi cup on them out. And I gave them a mask, and they're supposed to put them on. And sometimes they get kind of slack, and I catch them, and then they put them on because I don't read them the right act. But they don't. I don't think you need to. If you do that, you're not going to create particulate floating around the room. It's just vapor. Okay, so I don't think you need to be gowned up totally. But you know, with COVID, what are you doing? Probably wearing a face shield now and some kind of mask. You could change your mask to one of those little black ones that have the little particulate thing on there. It'd be better with COVID than what you're wearing also. But still, don't polish them. Okay, don't polish them out. So if it's a tooth that's got a big occlusal buckle, don't polish it. Skip it, okay?
Is there anything to the fact that high levels of oxygen would further open the blood-brain barrier and expose you more to the mercury?
Well, don't know. It's not on there for a short period of time, and I don't know the answer to that. I really think I really believe with our protocols for patient protection, they're not getting much exposure at all. I mean, I can't tell you it's zero because we haven't done the blood tests or the studies to show that. But I know it's as small as we can get it. So oxygen usually is convenient in the office. You know, it takes some engineering and finagling to get a air compressor run in there and to be able to do it. But if you want to spend the money then for that initially up front, then you're not spending the money for the oxygen. So probably in the long run, it's going to wash out. I just don't know to tell you the sources that can do that. Jack Call has Jack has his hooked up to his air compressor. That the oxygen, you know, the air that's in your syringe and stuff. Okay, you might talk to him about that if how he did it.
So going back to the polishing, if we're using the EMS airflow system with the erythritol powder, what is do we have any studies on how much vapor is released through that process?
No, I don't. I would say it increases it when it hits the amalgam. And you're creating, and then you're potentially, I don't know if you're creating mercury particulate or not. I don't have any studies there. I wouldn't tell you not to use it because most of that stains in the lower anteriors where there's not, the worst part. You might skip that tooth. You don't have to use it on that tooth. Just don't use it because you got to use it. If you don't have to use it, I'd skip them. There's no science to say don't use it. Okay?
Are there any studies what that mercury vapor includes? What does it have? Is it just the mercury
It's
ions?
elemental mercury.
So if you have a 40-year-old amalgam filling, what happens to that filling? Does it shrink? Does it get brittle? What happens to it?
Well, they usually get bigger, don't they? You know,
I don't
because they
know. I
creep,
have
because
thought
they,
it-
oh, they do, because they creep. Over time, a filling creeps. It actually expands. And the more moisture it's exposed to, the more it expands. And that's why they crack teeth over the years. You know, 40-year-old filling, all of a sudden the tooth will crack apart. It's because that thing's putting pressure on the whole time it's in there. But there's never no mercury in that filling. Just because the mercury vapor comes off, the mercury doesn't go away. It emits vapor the whole time it's in there. It's just what mercury does. I mean, it has a half-life of what, 50 to 100 years. So in 100 years, half of it's gone. Another 100, that half's gone. It's always going to be there. It's always there.
Where are we on?
2 minutes. Is that all of them? Oh, there's a question over here. I'm sorry.
My bad.
She'll get there. We got.
Yeah, that way so our live stream can hear you too. I know I've been spending all morning. It feels nice to move around.
So some people are more sensitive to the fillings, but there's never one person who's like never affected at all by.
Well, there's one genotype, and they look at the APO series of genes, and there's 4 combinations, and there's one combination that dumps mercury like crazy. Just doesn't absorb it. The body just gets rid of it. So they probably don't show. So you gotta they're like the person that smokes till they're 100 years old and dies comfortably in old age. So you got these patients full of mercury in their mouths. They don't have any problems. They're completely healthy. They got those genes.
What's the name of that gene?
APO 3 and 4.
Thank you.
And the different combinations of them make them. Yeah, you can find out under, yeah, Google those in association with Boyd Haley. And you'll see it. Google Boyd Haley and APO, just 4 probably, and it should pop up his research. Okay. Thank you. All right, I enjoyed it.